Just, yeah.
Well, good evening everybody. Thank you for joining us either in physical form or remotely online as well. I'm delighted to be able to introduce our guest speaker this evening, who is one of our visiting professors in the School of Health and Life Sciences. My name is Tim Thompson, I'm Dean of Health and Life Sciences, and so I'm particularly interested in what people will be talking about this evening. Now, Peter has got an illustrious career so far, so I'm going to read from here, my book paper here, so I don't forget any of the important things that he has done. Peter joined Public Health England in September 2016 as Centre Director for the North East, having previously been Director of Public Health for Stockton-on-Tees Borough Council for 4 years. Before this, he was Director of Public Health for 11 years in various NHS posts in the North East of England, including 2 years as Acting Regional Director of Public Health. In May 2020, Peter took on the role of PHE Regional Director and NHS Director of Public Health for North East and Yorkshire, and his responsibilities included leading the provision of a high-quality, responsive, expert public health service to support the work of the local authorities and NHS partners in the North East and Yorkshire. Peter started his career as a medical statistician, following completion of his PhD in statistics in 1987. He worked as a lecturer at Newcastle University Medical School until 1996 and was the founding director of the Centre for Health and Medical Research here at Teesside University until 1999. He joined Pfizer Pharmaceuticals for a brief spell before joining the NHS in 2000. He also had 4 years' experience as an acute hospital non-exec director, including being the Trust Vice Chair and setting up and chairing their original Clinical Governance Committee. He joined Tees Health Authority in 2000 and has held senior public health roles in the North East since then. Peter's talk is very pertinent, I think, to what we're all experiencing at the moment, and there will be an opportunity for questions at the end when he's finished. Peter, thank you very much for joining us.
Thank you.
And I'll hand over to you.
Thank you, Tim, and thank you for the invitation to Teesside University. It's an immense privilege to actually be here this evening. I always love these type of lectures. It's great to be back in the room like this for me. I've done, over the last 2 years, a lot of online, quite a lot of online teaching. I've opened conferences, I've done keynotes and conferences all online, but it's the first time this evening I'm back in the room. So I'm really looking forward to this, and I'm very, very grateful for the invitation. I am speaking here in my capacity as a visiting professor at Teesside University, and I just think it's important just to refer to that at the beginning, because I am actually a fairly senior civil servant in my day job, so I'm not here representing the Department of Health or the government in that sense in terms of my comments this evening. Everything I shall talk about this evening is actually from public source information, apart from one slide. The rest of it is all available in various places, and I've pulled together what I would hope is a bit of a narrative and a story almost around health inequalities and how I think we can do something about them. So if I just... We've just heard some of that stuff. I'll also mention at the bottom, I was made chair of school governance for 8 years while I was doing all of that, so I know a little bit about schools and the press of Ofsted. I was chair of a voluntary sector organisation, a trustee of ASH, and I'm an ex-football referee. Actually, while I was here, I was a football referee. I retired from refereeing the year I left Teesside University because working for Pfizer and refereeing was just totally incompatible. So I'm also an ex-football referee as well, something which I really enjoyed and thought the referee last night in the Borough match was actually quite good, even though we lost the game. So, I'm going to talk about health inequalities and opportunities for prevention. I'm going to do it in reverse. So I'm going to describe some inequalities, a little bit of history in inequalities. I couldn't possibly do a session like this without a little bit on the pandemic we've just been through, or we are still going through. So there'll be a little bit on that as well early on. And some of that will reflect some issues on inequalities as well. But I want to start with a map. A map which pretty much describes the problems we're facing. So what the map is showing is the mortality from causes considered preventable. And these are directly standardised rates. It's the most recent data from the Public Health Outcomes Framework. And the darker the colour, the higher the death rate. Dead simple. Red is statistically worse than England average, amber is England average, and green is better than England average. That shouldn't surprise anybody in this room, online. It's very, very sad, it's incredibly unfortunate, and we've known this for a long, long time. The question is, what can we do about it? So when the pandemic came along, there was actually, in the first part of it, quite a lot of surprise that people who were more socially disadvantaged died at a faster rate than people who were less socially disadvantaged. The mortality rates early on was quite clear that people who were from the lower deciles and quintiles of the socio-economic distribution basically had a higher mortality rate than people at the top end of the distribution. And that was in the media, and politicians were talking about it, and I was surprised anybody was surprised. It was barn door obvious that was going to happen. And there wasn't a single public health professional in this country who didn't know that. It was really obvious it was going to happen. It is what happens in this sort of pandemic. People who are in the lower socioeconomic deciles and quintiles live in high density housing, closer together. They're in occupations where they couldn't work from home and be protected in that space. If you remember the first phase of the pandemic, when the first lockdown came, a lot of people, if we wanted to eat, if we wanted to move around, if we wanted a lot of basic services, people had to go to work. We had massive outbreaks early on in food factories, because food factories, there's lots of people crammed in together on production lines in temperatures which are quite low, which the virus loved. And guess what? We had a lot of outbreaks in them. And quite a lot of people were quite poorly. But the people who work in those environments tend to be in decile 1, decile 2, maybe decile 3 of the socio-economic breakdown. And the mortality rate, as you can see from this, the turquoise is men, the reddy purple colours is women, and you can see the gradient as well. And again, don't be surprised at the gradient. I'll show you lots of this in the next 45 minutes. The gradient in inequalities, whether it's lowest decile or quintile across the highest, is quite stark in many, many areas. So inequalities came shining through straight away in the pandemic, as it did for ethnicity as well. Again, quite early on, this data is just from the first wave of the pandemic. It's only till the 13th of May 2020. So now the first wave peaked 2 years ago and 2 days from today, the 9th, 10th of April 2020. That's when the first wave peaked. So by the end of May 2020, 13th of May, 2020, we already knew this. Quite early on. And you can see again, first of all, mortality rates higher in men than women. And we knew that quite early on. And it stayed like that pretty much through the whole pandemic. And that's consistent across most age groups when you look at age standardised rates. And you can see there, there's two things at this actually. You can see first of all the highest risk are people of black ethnic origin, then Asian origin. The other group's very interesting. The reason the other group is actually quite high is that what we discovered was we were rubbish at recording ethnicity. There was a lot either missing or it was partially recorded or not very accurately recorded. So the people doing the coding just lumped it into other. And that's one of the lessons in this. How do you know whether you've got a disparity or an inequality in a distribution if you don't measure something as critical as ethnicity? So you have to, and so one of the lessons we've learned already is that the NHS has already got much better at recording that information and then making sure we can track back against outcomes. However, just very quickly, this is not a history lesson, but we've had a few pandemics in history actually, and you can look at any one of these. I could just give you a few mortality rates, so then you can have a little think about the mortality rate we've had for this one. So apparently, and this is my little bit of research, the plague of Athens wiped out a quarter of Athens. The Antonine Plague wiped out about 10% of the Roman Empire. The Black Death, depending on which, there's loads of research on the Black Death, and probably somebody in the audience knows more than me, but the lowest estimate for mortality of the Black Death I've seen is 25%. The highest is 60%. Most estimates put a third of Europe and the Middle East died in the Black Death. Great Plague of London, 1665, 15% of the City of London died. And then, if you look in recent times, in my lifetime, I was born in the early 60s, Hong Kong flu pandemic, 68. People forget about that. My mum was a nurse then, and she tells me she remembers that, in nursing people, and knowing somebody who was a young adult who died of it. Not often talked about, but quite a serious one. The AIDS pandemic. My university years, the early 1980s. Some people who will remember the AIDS pandemic when it started, and the huge public campaigns around the tombstones, and the massive campaigns around safe sex. Really massive public information campaigns, which were very effective. The swine flu pandemic, 2009-10, and before the COVID pandemic, the Ebola epidemic, 2014-16, we had doctors in this country stationed at Heathrow Airport doing temperature checks as everybody got off a plane from parts of Africa. And they were on 24/7. I had staff of mine in the North East who went on a rota down to Heathrow. So we were very concerned as a country. It was highly unlikely that Ebola would actually survive in this country because it's a tropical disease. But nevertheless, that's how concerned the Department of Health became at the time. And then obviously the current pandemic. Hugely an impact on our lives which we probably couldn't imagine. Mortality rates. I'm not going to show too many statistics and numbers, but look at the median column here, basically. That's the median of the estimates. The overall, this is by the, this is the one internal slide. So this is by the 14th of October 2021. So it's after the so-called Alpha Kent variant, it's after the Delta variant, which is the Indian origin variant, we call it, but it's before the Omicron variant. So this is last October, up to last October. And the overall mortality rate is estimated at 0.18%, around 0.2%. But looking at that by itself is pretty meaningless. You have to look at it by age band, because the risk varies enormously by age. At the top, and to be honest, even this isn't that good. So 75 pluses, the risk is 2.6%. So rough, in round figures, 1 in 40 people who contracted COVID, aged 75 and over, died of it. Two things in this though. Firstly, it matters enormously, 75 plus. It will be a better representation if it was in 5-year A bands, 80, 85 plus and 90 plus, because the risk continues to go up very, very fast. The risk at 85 is more than double the risk at 75. So it goes up very fast still. And secondly, these are almost certainly overestimates, because there are two parts to calculating a rate. There's the number of people who have the event, i.e. die, and there's the number of people who are infected. You can count the number of people who die because you can observe them. You can count them. But we've always known we're undercounting the number of infections, because you only count those you find, and they're the ones you test. So if people aren't being tested, you're not counting them. And if people are asymptomatic, and we know that around 1/3 to 40% of people who've had coronavirus are asymptomatic. And if they weren't coming forward for testing, you're not going to find them. So those figures are almost certainly overestimates. So I'm putting that in context. Of course, there's now 7-8 billion people on the planet. When we had the plague and the Black Death, the population of the planet was around 500 million. So, again, the huge impact on that population. And very massive impact now volume-wise, and those huge impact on our lives. The mortality rate, tragic disease as it is, if you look at younger ages and all the work that we've done in that, the figures are really quite small. So for children, we've been really worried about children. I completely get that. Children under 4, the mortality rate is 1 in 175,000. And those who've died, every single child has been, tragically under that age, have been a child who had very short lifespan anyway because of congenital or other very serious disorders. So moving off that a little bit, another quick pattern here of the pandemic, and then I'll move on shortly from the pandemic. The Chief Medical Officer said very early on he felt the best measure of the impact of the pandemic would be excess mortality. Because of the difficulty in defining whether somebody was a direct COVID death or indirect COVID death, whether it was associated with the cause of death, etc. So the top one here with the, again, the turquoisey figures, they are excess deaths over the previous 5-year average. So it starts at the left-hand side at January 2020. So week 0 is the first week of January 2020. And the first 10 weeks of 2020, we were slightly below seasonal average. And the reason for that is that in the last 6 or 8 weeks of 2019, we had a very early flu season. And what, again, people either wasn't much publicity about that people don't know, is there were 11 or 12 children in this country died of flu in November, December 2019. I know 2 in the North East because there were tragically cases my team dealt with. So more children died of flu in those 2 weeks there, those 2 months there, than died in the whole of the next year of COVID. Just ordinary flu, by the way, ordinary seasonal flu. So then we had this big hump of excess deaths, which kicked off in the middle of March 2020, peaked on the 9th, 10th of April, and came down through into early June. And then we had a very quiet summer. Then during that summer, we had a bit of a pickup around August time, end of August, early September. It picked up again slowly, but now you can see the pattern of the deaths is different. We had a very short, sharp, big hump and down. Here we had a steady growth. And what happened there around November, December was what was called the Alpha variant that came out from Kent. And that came through the population. But we started the vaccination programme on the 8th of December 2020. And I always remember because my mum was in the first day. She lives in Middlesbrough. She had an appointment with James Cook and she got done the first day. So I always remember that. 8th of December 2020. And that impact, you can see how quite quickly it comes down then, the beginning of 2021, because the vaccine had a pretty fast impact. The vaccine has been an incredible work. It saved thousands and thousands of lives. So you see the next year, as you go through 2021, through a whole chunk of it, we were then below seasonal average. And then, as we've gone into the winter we've just had, it's crept up, but not a huge amount above. And this is when the Omicron variant hit us. And the reason Omicron, which is very infectious, and you know, there are people who are quite poorly, but they aren't people who've become severely ill, where they need as many people in intensive care or as many people dying, because the vaccine's doing its job. So the impact of Omicron, which is the most infectious yet of the variants, has been really mitigated. And since January, you can see we've had 10 or 11 consecutive weeks in this year where, again, we are below seasonal average. And the other reason is we haven't had a flu season for 2 winters. Because in a bad winter, flu will kill 20,000 people in this country. An average winter, it's 6,000 or 7,000. But we've had 2 winters without a flu season because of social isolation. People haven't been spread. The opportunity for flu to spread hasn't been there. So there's just a little bit around patterns of the pandemic I thought would be interesting to start with. So I shall move on to a bit more inequalities. So inequalities have been with us a long time. I thought I'd just go back to the 1840s, and I wasn't there for the 1840s before anybody, any wisecracks in the audience suggest that. But inequality has been with us a long time. Liverpool, 1840, the average life expectancy for a man was 26. 26. Even in Surrey, the best part of the country, in terms of life expectancy, there was 45. So, and that was what life was. We forget that. They were lifespans through those decades. The inequalities there as well, of course, you can see. And you can see 2010, I've picked up this bit of data from, still the same order, Liverpool, London, Surrey, still an inequality, but obviously not like we've once had historically. Coming closer to home, this is the most recent data for our part of the world. So I've done this in terms of North East and North Cumbria because that's the unit upon which the NHS now operates. The integrated care system for North East and North Cumbria operates at this unit, so I thought I'd show the data at this unit. And you can see that from 2001 on the left-hand side, for a good 10, 11 years, there was a steady rate of increase in the national life expectancy figures for both women on the left and men on the right. And that there was a pretty much parallel increase in our part of the world. I wouldn't like to claim at all that we narrowed inequalities, but we kept pace. You can see the slowdown started around 2010-11-ish, and the most recent data does show, quite worryingly, quite significant drops. This is all, the actual data itself, by the way, this is not contentious, this is all well known and published. We could discuss all day. We could have a whole seminar discussing that one graph, I'm sure. But we won't do that. But I just thought I'd put that up for starters. This shows well the consistent inequality between the North East and North Cumbria and the rest of the country. Our lives are shorter in the North East than if we were an England average town. Yeah. And again, if you want to look at that, it's a bit more at a place-based level. Middlesbrough, where we are now, my hometown. You can see Middlesbrough, sadly, at the bottom, quite a way behind the rest. Eden at the top is basically the Penrith area of Cumbria. Beautiful area. It's like frankly, it's like, to some degree, I'd describe the Surrey of the north. It is a very affluent area, and with affluence comes health. Wealth equals health, absolutely, in any study you'd care to look at. And again, you can pick out any areas you're interested in there, but the interesting here is the pattern. Again, the wealthier areas at the top, the areas with the greater socio-economic challenges at the bottom. Not a surprise, all well known. Have a closer look at one of our local towns, Stockton, not very far away, where I was Director of Public Health. This is a piece of work I did for one of my DPH reports in Stockton. And I want you to look at particularly the left and the right-hand ends of this graph. The left-hand end this is by deciles. So the lowest 10% of men in Stockton had a life expectancy even lower than you would think from the slope line there. So about 68. The top end, I live in the borough of Stockton. You know, you'd put me, frankly, at the right-hand end of this in terms of income. Life expectancy is 85. So the top end of Stockton is doing as well as anywhere in the north of England and as well as almost anywhere in England. It's the bottom end is stubbornly staying there and isn't moving. And the gap's getting bigger because the top end is going further away and the bottom is just sat there and isn't really improving yet. Another way of looking at it is some of the trends over time. This is life expectancy for men. The black line's England, the yellow and reds are Stockton. Pretty much over 20 years, it gets a bit closer to the odd year, then it gets a bit further away. But really, I would say over 20 years, we're pretty back now where we were 20 years ago in terms of the gap. So the gap in life expectancy hasn't really budged much. It's gone up the odd year and down the next year, but over time, that hasn't changed much. Middlesbrough is gravely concerning. Middlesbrough has not only the gaps, first of all, wider, and the gap held its own from 2001 to about 2009-10, and since then, that gap's got bigger and bigger and bigger. So the inequality between life expectancy for men, like with the same for women, by the way, in Middlesbrough, is growing in front of us. It's not narrowing. That is a problem. I'm going to move on from healthy life expectancy. I don't want to talk too much. I'll skip on that one, I think. Oh, come on. Next slide. There we go. Another little look at Stockton. And again, just to make a point here about how important it is to understand the whole population you're dealing with. So again, a piece of work we did when I was at Stockton, we looked at Lancaster, because Lancaster is actually socioeconomically quite similar to Stockton with all the indices, and then Newcastle and Stockton. And what I want you to think about here is at the left-hand side, for say Lancaster, you're looking there for males, females and all persons, because it is important sometimes to look differently men and women, to the least deprived and the most deprived people in Lancaster. And surprise, surprise, these are age standardised mortality rates. The rates are much higher in the most deprived areas. The ratio from the most deprived to the least deprived is pretty similar to the one in Newcastle, from the most deprived to the least deprived. It's not exactly the same, but it's in the same ballpark. If you look at Stockton, so Stockton's least deprived, so the people like me who live in Stockton, have the lowest mortality rate compared to Newcastle or Lancaster, and the people at the bottom end of Stockton have a much higher mortality rate than the people at the bottom end of Newcastle. So you live in the bottom 10% of Stockton, you do worse than if you're one of the poorest people in Newcastle. Don't know why, but it's quite clear there's a quite a difference there. And then if you look at what age it starts to kick in, it starts to appear at age 25 to 44. In the most deprived areas, the mortality rate starts to increase as young as the 25 to 44 age band. And then it gets bigger and bigger as you go through. So the inequality, mortality and risk of death kicks in early. It isn't something that waits till you're 65 or 70 and all of a sudden I'm in a poor part of town and you die. It kicks in early. The mortality rates start earlier at a higher level in the most deprived areas. And again, the right-hand side, you see the difference between the pinky one for Stockton's most deprived and the dark browny one for Stockton's least deprived. And again, the difference between those two is much bigger in the ratio than between either Lancaster or for Newcastle, suggesting really their populations are flatter. And again, inequalities, a critical element is, and I'll say more about this later, is poverty. This is the picture of children living in poverty. So the darker the area, the more children living in poverty. The entire North East of England. And the whole belt of the M62 and across to Lancashire and the North West. It's really quite sobering, really. In terms of my patch, it's all that bit in the red at the top, and it goes from Hull across the M62 to Bradford and Huddersfield and then Sheffield. It's all part of my responsibility, my day job. And of course, if children low-income families, that means the households are low income. So you can take this as a very good proxy for distribution of poverty. Just look at that base as a map of poverty. You get a lot more poverty where we are now. And if you look at the data in terms of how many people compared to England we have in our deciles, so I'll just explain the top and the bottom one. So if we were distributed the same as England, we'd expect 10% of people in the richest decile. We've only got 6%. If we were distributed the same as England, you expect 10% of people in the poorest decile. We've got 18% in the North East. That matters enormously because it has enormous impact on services. So this is the impact on health services now. So this again, left-hand side, the most deprived decile, to the right-hand side, the least deprived. The blue lines are electives, where people have a planned appointment for an operation or procedure in a hospital. The red lines are emergencies, where people go in for an emergency reason for a procedure or operation hospital. And ideally, what you would want is a high elective rate to try and prevent emergencies, because you're doing an early intervention. And you can see the richest part of the North East of England, there's a far higher number, and the right-hand side, really from about the middle, deciles 6 and 7 certainly going across, you've got a far higher rate, not far off, double in the richest end, of people going for electives rather than emergencies. Look at the left-hand end, it's almost equal. And also on a volume basis, because these are counts of admissions, the volume basis, you see far higher volume of people using NHS services from the more socioeconomically deprived deciles. So the impact on services is enormous. So if you have a health service and social services, by the way, it's entirely the same applies to social services. You've got a health and care system where you have more than your share, if you like, of people in each, particularly the poorer deciles. You get a heck of a lot more pressure on your services. Pressure on your services means you need more staff. It means the staff you've got work harder and longer. It means that people actually often have to wait longer because they can't quite get the access because there's so many people waiting. So you wait longer for cataracts, for hips, for knee operations, for cancer operations, for bypasses. And there's more pressure on services. So it matters a lot in terms of how we actually, the impact on services and therefore what we have to do with it. Even down to simple in accident emergency presentations. To James Cook at North Tees. Again, you see this is from a group of GP practices we've looked at. Again, you can see so clearly the gradient going across from the left-hand decile to the right-hand decile. I did say at the beginning you see lots of these pictures. Sadly, you do get this pattern all the way through. And a couple of things again which we have to, in small volumes but tragically high rates, these are deaths from drug misuse. This is Hartlepool. You can see that it was high 20 years ago. We managed to bring it down, stabilised it. We never quite closed the England average, but we stabilised it. 2011-12 started to take off. And you can see drug-related deaths still climbing rapidly in Hartlepool. Middlesbrough, even worse. Even worse. Again, you see the drug-related deaths per 100,000 climbing steadily in Middlesbrough from about 2010, 11, 12, having stabilised it for a number of years. Now, the government has thankfully put in £780 million in drug services, which in fact the allocations are coming out next week, I think, to local authorities, and local authorities such as Middlesbrough and Hartlepool are getting their share of that £730 million over the next 3 years to address precisely this. The very specific aim is to bring these figures down again. However, whilst that whilst that contributes towards reducing an inequality, because the people who are sadly dying of drug misuse are people for the main who are in deciles 1 and 2, so it helps, but it absolutely does not solve the problem. It is nothing more than it's critical for these people, but in the big picture, it barely touches it. So I've talked about health inequalities so far, and I just want to just a little bit touch on what I mean when I'm talking about them. And you get different definitions. They all more or less say the same thing. Health inequalities are simply differences in the health status, and that status could be a determinant, or experience, or an outcome, described by different population groups. So you could look at ethnicity, look at age, and I've been looking largely at socioeconomic distributions here. And of course there are interactions between ethnicity and socioeconomic distributions as well. You must remember that it is actually quite complex. And so the first thing often people talk about are what we call structural issues: housing, education, employment, income, those type of things. And then the second group are the things that we do. You could say the things a lot of people enjoy: smoking, harmful drinking, poor diet, lack of physical activity, those type of things, the lifestyle things. And there's often a tension between, do you try and address the structural issues, or do you focus on what's called personal responsibility around the unhealthy behaviours? So you smoke, you're harmed by it, it's your fault because you smoke. You drink too much, you're harmed by it, it's your responsibility to drink less. You have a poor diet, it's your responsibility to drink less, it's nobody else's fault. The fact that you can't buy affordable, healthy food, or that alcohol is very widely available at cheap prices, or that you are addicted to alcohol or addicted to smoking, doesn't come into it. Or you've been brought up in an environment where smoking is the norm, because you follow a norm. And we know there's very strong norms in smoking and non-smoking populations. So it's far more complex than either one or two. It's the interaction between one and two we've actually got to look at. So I don't, and some people in public health do actually sway towards either more structural issues or sway more towards, and certainly there's a political philosophy sometimes more towards the personal responsibility bit. In my practice, if you like, as a jobbing director of public health over many years, I've always found you have to, you're dealing with the interaction of the two, and not a one. If you deal with one or the other, you'll fail. It's the interaction of the two, I've always felt, and that's critical. And increasingly, access to services is being paid more attention to. That's really important. Do different groups have equal access to services? And do we have to work harder to make sure all groups do have equal access? And that'd be controversial. Should we actually make sure some groups have better access? Because they start off disadvantaged, so should we give them more access for those who are advantaged like me? And I think there's a strong case for that. Again, just another example is cardiovascular disease. Just look at the right-hand correlation, the graph there. Just a simple correlation. Along the bottom, we have mortality, preventable mortality from cardiovascular disease. Up the top, we have deprivation. And nobody will be surprised by now that, again, the more socioeconomic deprivation you get on a population basis, the more deaths, early deaths you get from cardiovascular disease. And exactly the same for cancer. Again, I won't dwell on it too much. I think I made the point over the patterns I actually wanted to get across. So I'm going to start to do a bit more now about the good news and what can we do about some of this. The first thing to notice, and this is one of the, you get many representations of public health. This is one of the ones I like from Dalgar and Whitehead. And you'll notice, if you can spot it, on the right-hand side, a little segment of healthcare services. There's enormous political, public, media interest in the health service. Depending which bit of research you read and, or into how you interpret it, health services contribute something like 10 to 20% of the impact on health inequalities. Turn that round. If we had a perfect health service, you would not have addressed health inequalities in this country by a long way. Not by a long way. You have to address the environment, education, housing, poverty, money, wealth, distribution of wealth, distribution of housing. You have to give, as Marmot said, every child the best start in life. You can't address it just through health services. Important as they are, and we all need them at some point in our lives and our families do, critically important as they are not the solution. They're a part of all of this big picture. And local government and what we do locally is a massive part of this. And local government for many years has had a role in health inequalities and is a part of the solution. Going back to the early, there's been poor laws for 1834, there's been a raft of poor laws, but that was one which introduced powers for local groups, parishes, to actually take control of what were workhouses in order to improve the health and well-being of the poor. It was an organised effort of society to try and improve the health of the poorest. When the NHS was created by Nye Bevan, he created it and he created the health service because he'd felt local authorities had become too small for what was needed. Up until then, the local authorities had an awful lot of responsibility for health services. Local authorities ran ambulance services and what were then children and family services, sanitation. NHS created in 1948 into one big national service. Again, as Nye Bevan said, he didn't think local authorities could do, he thought they'd become too small because of the scale of the task that was required. This chap, very well known, for anybody in Stockton, and actually I would say across Teesside, George McGonigal, Chief Medical Officer of Stockton, 1924 to 1939. He was quite controversial in his times. He was producing his own research locally from Stockton in the 1920s and 30s, demonstrating that actually it was poverty that was causing the excess mortality in Stockton rather than lifestyle factors. And he had some very good work on that. He's quoted in Hansard. He was very controversial in his time. And he had that very famous statement, again, as true now as it was then. And I'll be finishing off with another one of his quotes towards the end. But again, as we move to try towards solutions, there's been lots of different efforts at solutions to organise how we deal with public health and all of these challenges. There's lots of reports being done, which I'll reflect on in a second. But we tended to reorganise a lot. So Public Health England was created, for example, recently in 2013, was abolished last year, lasted 8 years. We've now created, so I'm now the Office of Health Improvement Disparities, which is one of the successes of PHE. And we have integrated care boards, which are an NHS concept and construct, following lots of reorganisations. I've just been through my 8th reorganisation in 25 years in the sector I've worked in. So we do it very, very regularly. We move those things about, and I think there's a focus on the structure, not a focus on the problem when we're doing that. What you can do locally in place-based, so he's got to get the solutions now, and what we can do about it. So New York, the Mayor of New York has a lot of powers, like the Mayor of London does. And so, when they were really pushing on smoking, we talk in this country about increasing taxes on tobacco, and it goes up 2 or 3 pence above inflation at different budgets, and we worry about the impact on inflation of various things. In New York, they pretty much they added 24% in one go to the price of cigarettes, and they've continued since then to basically try to tax it out of people's reach, because it is still by a distance the #1 preventable cause of death, and it disproportionately hits the poorest people. More people who are poor die of smoking than people who are rich, put bluntly. Oklahoma, you might know America has a huge obesity problem, and so the Mayor of Oklahoma tried putting the entire city on a diet. Now, it may or may not have worked, and you see here the claim to have, a lot of people to have lost a lot of weight. But locally, I'd love to see some really strong, passionate local political leadership and vision. Say, right, in Middlesbrough, you know something? We've got an obesity problem in Middlesbrough. 150,000 people live here. We won't lose £1 million in weight over the next year. Or we want to do an extra 10 million steps in the year. Or we want to halve the number of smokers. Some really radical stuff to really start push some of that. Or we've got to make sure everybody in Middlesbrough has a warm, dry house. How about that? That'll be a good start. And really then put a policy in place to get to that point. Because if you did that, you'd reduce hospital admissions for all sorts of things. And you'd improve children's education because they'll be off school less, because they haven't got as many infections. So big things like that can be achieved. But you need a real focus on them, and it needs someone to step in with a plan to do it and drive it through. And you've got to actually, and this is where the drugs example, the reason I showed the drugs example earlier was really in contrast to this slide, because it's very tempting to just go the highest risk people in small groups. So, for example, people driving drug misuse, tragic for that group of people, and it absolutely must provide the very best services we can. But as I said earlier, it won't budge inequalities one jot. You have to move the average of the whole population along, and you bring the bottom end distribution with you. And then, if you actually read Marmot, and these are Marmot's recommendations, but what Marmot would say in his report is that you also, at the same time, push the bottom up faster. He calls it proportionate universalism. So you've got to work harder and do more at the bottom end, but you've also, not instead of, but also got to move the middle as well. That's proportionate universalism. And these recommendations of Marmot are are hugely touted around. They are, I would buy into every single one of them. They're all excellent. And who would disagree with any of them? Wouldn't it be fantastic to think if we could move towards those goals in our society to really give every child the best start in life? Which is pretty hard in Middlesbrough, where 30% of children live in poverty. And to really try and create fair employment, good work for all. To improve that healthy standard of living for all, which means you start to narrow those gaps we've been talking about. Horsey's reports, we could go back to Black Report, to Nateson Report, and Wanless Report, and there's Marmot's Report. We're not short of reports on inequalities. These are reports across the north, just in the last, Better Health Fair was 2007-8, the other three are all in the last 10 years. Again, major reports, all of them demonstrating all the inequalities across the north of England. But I want to show a real success story, because you can do something about this. This is real data showing real success. So, in the North East of England, 25 years ago, the mortality rate for men for heart attacks was 22% higher than England and 25% higher for women. It was shockingly high. If you would look at Teesside was higher than that. So when I came into public health Teesside 22 years ago, it was around 25% then, heart attack rate higher in Teesside, mortality rate. Within 10 years, we'd eradicated the gap. That is not an accident. Around 2010, 2011, the gap actually does close for men and for women. Not by accident. There was a very rigorous programme put in place in the North East of England, of which Teesside is a part, and did its own part of the programme, to really focus on reducing mortality from cardiovascular disease. There was a massive programme around tobacco control. Our smoking rates went down faster than any other part of the country. That was the first thing. There was a massive effort around managing hypertension and cholesterol in primary care. That was really important. That made a huge difference. And we've invested millions in cardiology services at James Cook and also at the Freeman in Newcastle. Millions. And that had an impact, but that had the least impact. Important as it is, and we all want, if someone in our family has a heart problem, or whether it's us, you want the best services. And we have some of the best services in the world, frankly. I'm not exaggerating at James Cook and at the Freeman. The instruction in my family is, if and when I have my heart attack, just get me to James Cook, because they really know what they're doing. But actually, you'd save more lives if we put more of that money, even more of that money, into hypertension, cholesterol, and particularly tobacco control. And that's the dilemma we have. The attraction and the importance to the society of the treatment services, but the evidence tells us you'd get more bangs for your bucks and save more lives more upstream. It's incredibly hard to pull off because of the pressure on the whole system. And again, another way of explaining this, the North East of England now has the same mortality from heart attacks than the rest of the country. In fact, it's slightly better. We are below average to the rest of the country. There's only the South East and the South West do slightly better than us in terms of mortality from heart attacks. But what you see in that as well, the whole country's come down. So two things happened here. The whole country's come down and the inequality's narrowed. And that's what you want. So everybody's improved, proportionate universalism, and the bottom end, which is us, has caught up, proportionate universalism. It's a great example of it. This has made a difference. And it's through a really rigorous, systematic, at-scale approach. You can do it for this, you can do it for other things. Here's another example, completely different, teenage pregnancies. Again, the darker figures are 1998, the blue figures are 2014. It's a bit of an old graph I'm using here. First of all, you see yet again, the least deprived to most deprived, all the way around, the slope and the difference, and you can see over time how it's all come down. The slope has shallowed, but not sufficiently, so there's still quite a big gradient, but the whole thing has come down still. And again, that was not an accident. That was through a systematic approach across the country of better sex education, better access to contraceptions for young people, and better services talking to young people about these issues. It wasn't an accident. There was a systematic approach was put in place and monitored and measured across everywhere, and everywhere improved, and some areas improved faster than others. Prevention can be put into these boxes. I love this slide from Chris Bentley, who used to run the national support team for inequalities about 10, 15 years ago, and he put it into these boxes. So if you look at the example of teenage pregnancies, the risk condition on the left would be poverty, because you saw the graph there, discrimination, power hierarchies. The psychosocial risk will come to low self-esteem, and the lifestyle prevention bit will be access to, for example, access to contraception, knowledge of contraception, and risk-taking behaviours. You can apply the same to bringing cardiovascular disease down. Low social status, poverty, they're risk conditions for cardiovascular disease. Lack of social support, poor social networks, that you've got the norms that you live in, and then you've got behavioural risks. And again, you can go around as physiological risks at the top, the high blood pressure, cholesterol, deal with the medical issues. So depending on what it is, you can go around these different boxes and address things in different ways. I'll skip over that one if I can, and I think I've talked enough about that. So I'll talk about a few recommendations the last 3 or 4 minutes, which I've made over the years, and you might think this is a bit banal, what I'm saying here, but I'll explain why these are important. So my 2012-13 report, these are the only 3 recommendations I actually put in. And the reason I put them in was the story behind them. Reading to your child every day, in itself, reading is a vital life skill. And today, in our schools, there are children, 11, 12, 13-year-old, who have reading ages of 5, 6, 7-year-olds. What do you think their life chances are now already? They're already very poor. Now, so the reading bit, they haven't been read to every day. So there's the attention they pay to the child, there's the reading bit, the caring attachment part of the bond between the child and the parent, and the time they're giving them. That is all a part of that. And that starts to contribute to give every child the best start in life. Sugary drinks should be a rare treat. I mean, I've wanted for years to have no fizzy drinks whatsoever, any type, in any school, anywhere in the country, or in any hospital, or any vending machine, any university, by the way. They should be out. They should be a rare treat. And the hidden calories and the damage and the child obesity epidemic we are facing is really serious. And sadly, the pandemic has shown some scary figures, how it's got much worse when we've had kids at home. And no alcohol at pregnancy, the reason I put that one down was partly the time we were campaigning around it, but partly because it's a simple message. If you are pregnant or think you could be pregnant or wish to become pregnant, 0 alcohol. No messing, no saying, well, the odd glass here and there or a small amount, even though a small amount actually might not be that harmful, 1 glass of wine or one other, but that becomes something else. One person's small glass, another person's big glass. The simple, safe message to have a safe pregnancy in terms of the baby and the outcome for the baby is simply to advise, and it is advice, to advise no alcohol during pregnancy. And it's a simple message. There's no nuances to it. There's no what ifs or buts. I think sometimes we have to, as well, in public health, be responsible and simply say, this is the simple message. A few other things I've said a year or so later. And the reason I put these in is I think they resonate to today. So the first one is about pregnant women in services. And I looked at this, I was writing this presentation, the same day as the report in Shrewsbury came out, the Ockenden report, and the appalling litany of poor services there, and the tragic number of lives that were lost because of the awful services. And, they weren't getting the best healthy pregnancies or the best outcomes, those poor women there. Massively important. The second one is again about children. Giving children the best start in life is critical. The first 1,000 days is critical. There's a massive academic evidence base to it. Cognitive development, early nutrition, how important they are for a child, social development. Massive evidence base around it. We don't pay enough attention to it. I've already talked about fizzy drinks. And very quickly on physical exercise, again, I've done this word for word what I said 10 years ago, but the big part is the walking bit. The most of us can walk. And over time, if you do more walking, over time, it helps your cardiovascular system, use a little bit of weight, you're better tone. Actually, it's a really simple, free mass intervention. And not everything we could do to improve public health costs money. And then finally, I've already mentioned warm homes. In Stockton was one of the things I was quite proud of. We insulated 3,000 of the coldest homes in the borough as a public health initiative. We used, these are all two-storey street houses, a lot of them 100 years old, in the centre of Stockton, some older houses as well, and we insulated them from the outside, we cladded them. And, 3,000, I think everybody should know, I've said this for many years, for me it's the 21st century, one of the richest countries in the world, everybody should have a warm, dry home. I think that should be a policy objective. There are reasons to be optimistic. We have a levelling up agenda. The government is massively enthusiastic about this. There's a white paper on levelling up. There's a health disparities white paper, which is being written on that right now. I'm one of the advisors on that within the Department of Health, along with many other colleagues. The NHS has had a great focus on health inequalities now it's ever had in the 20 years I've worked in it. Huge emphasis on health inequalities. There's something called the Core 20+5 programme, which they're driving through hard. Integrated care systems, it's one of their core reasons for being, is to address health inequalities. And again, I've already talked about local government and local partnerships. And you cannot do this without local being at the centre, not on the periphery, but being at the centre of it. I love this quote finally, or one more slide of this, sorry, from George McGonigal. Again, he wrote this in the 1930s, and the 1930s, we know from history, was a pretty difficult time. Poverty, not ignorance, was the cause of morbidity and mortality amongst the poor. And this poverty is not the fault of individual families, but of a society that provided inadequate wages and welfare benefits. How powerful. How powerful. And something for us to reflect upon. Again, he's underneath that. He's addressing the issue of personal responsibility versus structure. He's addressing the issue of people who have a different perception of people are in society, perceptions of people. And he's addressing economic fairness and just redistribution of wealth. I wrote my own few words on that. And I suppose this captures my philosophy around this. We absolutely have to, as I put at the top, do a lot more about morbidity and mortality where we can do from diseases such as cancer and cardiovascular disease. We know what to do. We should do it systematically at scale and we should get on with it. And we do a lot of it, but we should be doing more of it. However, you read my comments here, poverty I think is more than just financial poverty. I think poverty of education, aspiration, positive role models, nobody reading to the child, poverty of hope and financial poverty, I think they're all critical. I think we need to address all of them. If you simply focus on personal responsibilities, that'll widen, not narrow health inequalities. You've got to do both. So it comes back to the earlier slide, the definition of health inequalities. It's the interaction between the personal bit and the structural bit. And all poverty in all of its forms is where we need to get to. And I do apologise if I've gone on too long, but I enjoyed that and I hope you did. Thank you very much.
So, thank you very much, Peter, for the talk. It was, I think, really interesting, also very sobering. And I think within that context, I think I'm particularly proud to be able to work within a School of Health and Life Sciences and within a university at Teesside that is actively addressing a number of the issues that have been raised today. We now have an opportunity for any questions from the audience, if anyone would like to ask Peter anything. Steve.
like public health, the best approach to public health is wealth distribution. And given the country we live in, that's not possible politically. So are we essentially resigned to the fact that the interventions will be throwing some money at stuff, doing the addressing it like, you know, cardiovascular, almost addressing this one piece at a time? I mean, things, for example, it struck me that, you know, the drive to insulate homes, about energy efficiency, would also impact significantly on public health. We don't hear that as part of the discourse.
Yeah, absolutely.
So do we need to broaden these?
Yeah, absolutely. So the question is for the people online is about the challenge of addressing wealth inequalities in a political context, and also the narrative around making arguments for changes, for example, in fuel poverty and housing, and making sure the narrative is also a public health narrative as well as an economic narrative. So first of all, let's comment on the wealth distribution bit. Wealth has been unequally distributed in this country forever, and it always will be. Let's not kid ourselves. There's not a society on this planet in human history has had a completely perfect flat economic distribution. There isn't one. There never has been. What we have to address is the poverty and relative poverty end of people in that. And you know, the economic distribution we have hasn't just come over the last 10 years. It's been stretched over the last 10 years. It's been difficult. But there were problems before then, and there were problems before then, and there were problems before then. So it's been around a long time, under governments of all types, and it changes with different times, but it's been there a long time. I think what we need to get better at in public health is exactly our narrative. And that's why whilst I'm very proud of the work we do around tobacco control and around reducing deaths from heart attacks, I would rather have made inroads into, I'll use housing again as the example, into poor housing. I am hoping that we could still work internally through government policies to improve housing quality. I don't think we should be, I know we're rushing to build more new housing in the country, but we should be rushing to build more good new housing in the country that are sustainable environmentally, that are completely well insulated, which also address therefore longer term poverty issues. I think the core two aspects to Steve's question there, the wealth part of it we'll never properly solve, but we have to. I think we can do more to mitigate the impact of on poverty in society, and I think the narrative is critical. I really think that's how we as public health professionals and leaders get that narrative across to demonstrate to people that the public health things we care about, it isn't just a moral or fairness thing, it actually brings real benefits to society. That was a lady.
Yeah, thank you, Professor Kelly, for such an insightful lecture. I have a question that what are the reasons for a high mortality rate in Stockton, most deprived area, in comparison to Lancaster?
Yeah, that's a really good question. And we sort of, so the question is what's the reason behind the very high mortality rate in the poorest end of Stockton compared even to Lancaster and Newcastle? Well, the best we've come up with is it's a measure of poverty. So within the poorest 10% of Stockton, you can find those people. Then you look at Newcastle and Lancaster, you can find the poorest 10%. There's simply a socioeconomic gradient between them. So the poorest in Stockton are poorer than the poorest in Newcastle, and poorer than the poorest in Lancaster. And because there's such a strong gradient, that gradient just keeps going. If I divided the population into into 20ths rather than deciles, you'd find it even more, you'd still find the same thing coming down. So I think we think the first most plausible reason is the poor in Stockton are poorer than the poor in the other places. The second, at the time, we think, is actually around how that's distributed within Stockton, within Newcastle and within Lancaster. Within Stockton, it tends to be very much concentrated and focused around the Oxbridge ward, the Tylery ward, the Portrait ward, right in the centre. In Newcastle, it's more distributed. So there might as well be something about the concentration and the associated socio-economic challenges in that concentration. It's a really good question. Thank you.
Thank you. Any other questions from? Yes.
You mentioned earlier about the government being
enthusiastic about levelling up
Yep.
and all things.
Yep.
But how much of that enthusiasm might be dampened by the fact that we spent a lot of money under COVID-19 and supporting the country? Are we anticipating that it might set us back a couple of years?
Right, okay. Again, the question is about the government's wish to level up and also the impact of the pandemic financially on the government's ability to level up. Yeah, fair? Yeah. So I've across all the different areas I interact with, you know, obviously I'm the Department of Health, the NHS, and all these different forms, and local government. I haven't genuinely experienced, first of all, such a desire to do something about health inequalities. Whether they're called health disparities or whether it's levelling up, I have not seen this desire in my career. Does it mean to do all the things I would recommend or people like me would recommend? But the first thing to have there is the will. And the will's there because there's a greater recognition of the problem than has been previously. Or for a long time anyway. The second part is the money bit. Well, that's a problem, sadly, for the country in everything. The pandemic has had an enormous economic impact. You know, there'll be research, there'll be PhDs and books on this for years and years and years as to how much of that money was well spent, how much of it was actually not as effective, what would the impact of the pandemic be if you'd gone this policy instead of that policy, how did our outcomes look like compared to Denmark or Sweden or America or China or India or Singapore, all those things. That's going to keep academics going. If I was you, I'd open a research school in it, by the way. It's going to keep academics going for donkey's years, all that stuff. And as part of that, the cost bit, there's absolutely a cost on all of society. I mean, you can argue the Chancellor's, one of the reasons the Chancellor's put up the national insurance is because of the cost of the pandemic. The pandemic has cost the Treasury tens and tens of billions. And as a country, at the end of the day, it's all our money. We are collectively paying for it. Will it affect it's bound to affect the government's ability to fund some of the policies we wish to fund. It absolutely would. But then events come out of left field, like the tragedy in Ukraine, will also have an impact on the government's ability because they'll think differently about defence spending. So events do come out of it. But I think you've got to stick to a pattern over time. Health inequalities have been there forever, and they'll be here for a long time. So we need a consistent plan and vision and drive, and you'll have a good period and not so good period, and funding will go up and down.
Thank you. Jack. Thank you, Peter. Really interesting talk. Really wholeheartedly agree on the role modelling around physical activity, diet, reading. I'm wondering, are we now seeing a second and third generation of parents who themselves don't feel comfortable reading? And therefore the role models aren't necessarily there in the home, that aren't necessarily active. Is this putting pressure on education systems, local authorities to take that proxy role of the role model?
Yeah. Well, I mentioned earlier, quite deliberately actually, one of the things I've done in my life, and being chair of the governor of a school, actually quite a nice area of Stockton, where my kids went to in Billingham. My daughter's a teacher. My wife was a vice chair of governors of the secondary comprehensive, and ran a post office for many years in the poorest part of Middlesbrough. So I get all of this. It is my hometown, this. And there's absolutely generational inequality. People have... the norm is not to be able to read very well. The norm might be to have children very early in life. The norm might be not to aspire to have a mortgage in your own home and to look after that, but to be rented. It might be to be in part-time jobs. The expectation isn't to come to a university like Teesside to learn, to better yourself, to get an education and to get a better job. I was doing a presentation in Winniebanks when we had New Deal for Communities, about 15 years ago this, when I was Director of Public Health for Middlesbrough. And there was something called New Deal for Communities. That was a £50 million programme which the then government put in place over 10 years. It was just for Winniebanks. £50 million into Winniebanks from about 2001-2 to about 2011-12, something like that. For those of you who, I'm assuming you all know where Winniebanks is in Middlesbrough, but you may not, but it's on the west side of Middlesbrough near the A19 bit. I was brought up a mile from there in Acklam. I know that area very well. And I was doing a presentation on, not dissimilar to this, only looking at Winniebanks in particular, and I talked about the importance of education and housing and good jobs. Because I've been talking about this for a long time. I'm particularly talking about good jobs. And I said, it was great when people from Winniebanks to go and be school teachers and nurses and to be serving our community. And a man stood up in the audience, got quite aggressive with me. We don't want posh jobs like teachers and nurses. Posh jobs like teachers and nurses. And I've never forgotten that. He got really quite angry with me because I was talking about posh jobs. I was from a mile up the road, you know, and he thought I was posh because I'm from Acklam rather than Winniebanks. And that mindset, I've never forgotten that interaction I had with that man. And we have to, that's why when I talk about poverty, I talk about poverty of aspiration. It's that lack of aspiration or poverty of hope that they can ever better themselves and live a better life. They're the types of poverty, Jeff, I'm talking about. That's what I've got in mind when I describe it like that. So there absolutely are those families, very tragically. And we mustn't give up on them. In fact, we must focus on them. We must help everybody, but we must find those families and help them more and more and more to help them and to support them to first of all, got to want to have the aspiration to improve. It's quite it's too easy to talk poverty in just terms of money. I think that's actually quite lazy, to be honest. Poverty comes in many different forms. I think that's one of them.
In Middlesbrough, so many times I've gone around and I've seen like less than 10-year-olds smoking. So I want to ask, is there any grassroots intervention to tackle this, or will there...
Okay. That's a really excellent question. The comment is about observing young children, Middlesbrough, 10 years old still, smoking, presumably in the street or in the park or around, and what can we do about it? Well, we've made huge strides in tobacco control. We've increased the age of sale to 18, we've got rid of vending machines, we've all sorts of things on packages of cigarettes. We've made it a lot, more unpleasant and harder. And, who knows, years to come we may even make it, you have to be older to buy cigarettes, the price might go up even more. But we've done a lot already. Clearly, those 10-year-olds, the fact that we banned it, you can't ban 18, they're getting them from somewhere. You come back to Jeff's question, actually, and the type of families they're from and the households they're from, and the aspiration. Where's the aspiration for parents who know their children smoke at 10-year-old? Where's the parenting? What's their hope for their child? So parenting, which we've disinvested in, and I do think actually you can do a lot more with good parenting, is critical. So we can do all sorts about trying to reduce smoking prevalence overall. There's a national target to get down to 5% smoking prevalence by 2030, which would be brilliant if we got there. And if we get there, people who are the poorest in the country will benefit the most, which is fantastic. That's what we want. But we still have children doing that. So that's where you've got to look at, again, that not hard to reach. We don't try hard enough to reach them. Families and those children, and to understand every child, and to have interventions in schools and interventions which support people. I don't believe for 1 second, by the way, having a stick and beating people and punishing people works one iota. It's got to be through education and explanation and role models. And it is true, you still get smoking communities and families and non-smoking. Absolutely, so you've got to address the norms. In fewer smoking communities where children won't want to do that.
Thank you.
My focus is particularly on maternity care. So it links in quite nicely to the question that the previous was just asked. There's been quite a reduction in kind of parent education. Obviously when school starting and that is gone. I know there's been quite a bit of privatisation. I know certainly from teaching student midwives that there's very little time and very little services seem to be out there, particularly in this area around parent education. I'm sure lots of the roots of that will tackle some of the things that we've discussed. And I just wondered if there was any local kind of initiatives.
Okay, so the question is about really parent education for expectant parents, and also actually I think a part of that is through what I'd call the making every contact count approach, where actually we also educate our workforce to take all those opportunities as well, whether it's midwives or health visitors, to support parents. There are various initiatives which local authorities, Director of Public Health would be doing. Rather than talk initiatives, I'd rather talk scale and culture, because it's fairly straightforward. I could take most of the type of areas we've even discussed in these questions, or I've discussed, and come up with a project which would have an impact with the right resources reasonably quickly in small groups. The challenge is doing it at scale. So how do we, at scale, improve the quality of parenting? And you have to start that, I think, before children anywhere being near parents. You start when they're children. It's a generational thing. We start with our current children and help them to understand the importance of the things I've been talking about, and build their self-esteem, build their hope, build their aspirations, build their communication skills, wrap them frankly in love and care. So that's what they become as they become adults. Now, you might think I'm getting now all sort of soft soapy and everything, because I'm a hard-headed statistician at heart, I promise you. But you really do need, as well, that culture shift. There's a saying in Africa that it takes a village to raise a child. And a colleague of mine who was Director of Public Health in Stockton for many years before me always reminded me of that. It's a community approach to children, and it starts there, and they'll become better parents. In the short term, absolutely, there are evidence-based, as you know, education things we can do to improve. But what I'd suggest is they need to do it at scale and to be built into core services, not being done by exception.
Yep. Fascinating presentation, thanks again. Quite interested in the system versus individual.
Yep.
I've got quite an interest in ecologies,
Yep.
systems design and behaviour change, particularly around exercise and movement.
Yeah.
So, in the context of that, I'm just wondering, is there a greater role that education can play as a social anchor? And what I mean by that is, can education at primary, secondary, obviously at university level, can they play a better role in creating a health-enhancing environment, not just for students, but for their families and community? Okay,
so the question is whether we can use education to improve the overall environment in physical activity in all its different forms. I think the very clear answer is a straight yes. The question for me is the issue will be, again, the type of education, because you have to, we're educationalists in this room. Education is, again, a very broad word, isn't it? You need education that you know is effective and works and has an evidence base that type of education works with different groups. But absolutely, yes, I'm completely with the premise. But you've also got to think about, I think, structural interventions in what we call the obesogenic environment that we live in. So this wonderful campus here, which is from the 23 years that I left, has evolved incredibly, is actually, it's a walking campus. You can't drive through it. There used to be a road through the middle when I was here, and a road the other way, actually, pretty much. I've just walked, all right, it's a short distance, it doesn't do much of my physical health, but I've walked 6-7 minutes to the car park to here. It's a walking campus. But, you know, could we do more in towns like Middlesbrough to make Middlesbrough actually more of a walking town? And how do you actually, the benefits of the environment, reductions in harm through air pollution, which we can measure, you get great benefits, but there are also economic costs and challenges to do it. So I think it's education absolutely itself can do that, but we'll never do this by trying to get everybody physically fit through the gym, because that's just a minority interest. It's more well-being related. And the well-being bit is, again, the evidence base around people who are physically well, and by that I mean physically reasonably fit, their mental health goes up like that. Again, exercise is really good for mental health and well-being, of all forms, whether it's physical tasks that you're doing or whether it's formal exercise. And walking is one of the most simplest things we can all do. It's cheap, it's free, it's something we can do and build our normal lives. And there are public health. I mean, I forgot his first name. Professor Muir from Oxford. It's one of his passions is getting the country moving again, walking.
So we have overrun a little bit, which I think is testament to the talk. So we'll have yours for the final question.
Thank you. I think riding on the last question now, my question is straightforward. Are there support systems for elderly individuals or groups of people who like to engage, looking at what is really needed for individual travel children now, from a question, and then or for families that want to, let me use the word rescue, using public health. Are there support system from the government, the Public Health England, NHS, to support individuals or groups who actually want to go into helping out? Because it's actually obvious that it's not just one thing that the government can do.
Yeah, absolutely.
So are there support systems?
It's a really good question. The question is about the support systems in place to help people help others, basically. Yeah, right. So summarising it, yeah. So it's a really good question. It's a good place to actually wrap up with. You're absolutely right. And you know, we focus sometimes, and I maybe have talked about government and government policies. Governments can't solve this problem. Governments can contribute to making it better, but governments won't solve it. People solve it. And particularly where you've got strong communities, you'll get people starting to help other people. There's a really energetic voluntary sector in the North East of England. There's a strong one in Middlesbrough. There's a strong one in Stockton. They are really well connected. I've spoken for many times at on the Black History Month, for example. Many times. I've opened it in times and I've funded it when it was in Middlesbrough Town Hall. And there's a very strong black community in parts of Middlesbrough where the community supports each other. They don't need government to come and tell them to do it, but there's networks there of groups of people. So people of similar characteristics in different areas. A lot of faith groups are very powerful at this. Are really good at supporting their area, their local people. So there's ways of coming forward. So I actually think community groups, the way I would facilitate it, if I was the responsible for some of the government money, I would vastly increase the resources to the voluntary sector and these grassroots people, because grassroots groups understand their communities best. And they'll identify people with the most need, and they'll be able to help them better, and they'll be able to set better role models. So I think the premise of your question is great. But there's not actually a systematic government top-down approach. But I do think it's just not right to, we can't say everything in government. We must do bottom-up and work through community groups in particular to address that. And that's where the opportunities to help are, local community groups.
Thank you very much. We have had some questions online, which you've actually answered through...
All right, okay, fine.
Again, I just want to say one more time, thank you very much, Professor Kelly, for what has been a fascinating and engaging talk.
Thank you.
And for addressing a subject which I think is eminently serious and sobering, but also giving us some reasons for optimism at the end as well. So I think
lovely. Thank you very much. Thank you.
Thank you.
Thank you.
Thank you everyone for attending.
Thank you. Thank you, Tim. Thanks for the invitation. Thank you.